we're here today to talk to you about a community Huntington's disease service and how this was set up in our area. And to cut this very short, I appreciate we have time to talk about it. In the Gwent area, as Martin has said, there's a real high prevalence of Huntington's disease in our area. At the time that we were considering this service model, there was no service whatsoever for people with Huntington's, with the exception of a HD management clinic in Cardiff. Locally, there was no expertise. I think it's fair to say there was very little interest in the condition. It wasn't seen as a priority. There were very poor skills and knowledge across the health and social care community, which led to inappropriate care. Certainly carer breakdown, that led to inappropriate hospital admissions, where individuals with HD became very dependent very quickly, and worse still, if you reached your middle to latter stages of the condition, very often you would end up being placed in inappropriate long-term care, generally out of county, completely isolated from your families. To develop this service, we had a major challenge because firstly, individuals with HD or their carers did not trust us. Why would they? Every time health got involved at the crisis stage, people generally would be admitted against their will. So that was our big challenge. And we were very fortunate actually in securing very quickly a relationship with the HD Association, who advised us in no uncertain terms of how we needed to go about engaging patients and carers. And that advice critically was that in the first instance we needed to engage informal carers in the service model. They were the ones who had been left to deal with the crisis situations. They knew what was wanted. So we set up a task and finish group. The Welsh Assembly had announced some monies for continuing care, but the caveat was the money wasn't just to be spent on people who were eligible for continuing care. It had to work right across the health and social care pathway. So the task and finish group was set up, which involved ourselves, social services, the Huntington's Association, Cardiff Genetic Clinic, external providers, and more importantly, informal carers. The consultation with the carers shaped the service model. They did not want a medical model under any shape or form, and they did not want long-term care being an option. What they wanted was a team of specialist staff who could actually maintain people's independence at home. Some of the challenges we faced in developing it was that, first of all, the Assembly were a bit worried, what if this didn't work in the community? Bearing in mind there was no service before, it could fail. So we had to build in along the pathway the potential for long-term care if needed. I mean, Jean will tell you later the success of that. The carers then were involved in developing the job descriptions, each of the job descriptions, and they were involved in the interviewing of the staff for the posts as well.
That's our team. We're all here in the room today. We're a variety of experienced clinicians from different professions. Our first task was to actually get to know, find out who our clients and families were. We spent a lot of time getting to know our clients and pulling them together. Not only just families, but also for a lot of our patients, they are looked after by staff in nursing homes, staff in the community with people with care packages. So we have a huge remit of systems that we have to work with. Our patients are also, they're a very complex condition, and they're supported by a huge network of different services. And we had to do an awful lot of work getting to know those services, linking in with them, particularly with primary health care now. We do an awful lot of best interest meetings with our colleagues there. We can help them as we are now, 2.5 years down the line, still experts in Huntington's disease and some of the issues. In secondary care, we can follow our patients into secondary care, where in the past they've been very poorly looked after. We can ensure their quality of care is maintained, their needs are understood in secondary care. We work very closely with the voluntary sector. We do presentations organised by them on an annual basis to our relatives and families with Huntington's in our area. We have linked in very close with specialist services with their own genetics and with the Huntington's Disease Clinic in Heath. And patients now have a monthly specialist clinic for we go with them to support their needs. Some of the things we've done, you've got these there ahead of you, just had a couple of things. We involve our patients and families fully in their care decisions. That's crucial, particularly with things like advanced decisions. We have to make a lot of advanced decisions with our client group. Since we've been established, just over 2 years now, we've had no admissions of Huntington's patients in our area to nursing home care. We've been able to find alternative accommodation for them if they need it in group homes, but most people are now supported in the community. We've had an uptake in genetic counselling. We have genetic counselling students on placement with us now. And because we have the local connection, people get to trust us, our families get to trust us and know us, and they will go to genetic counselling and stick with it. And we know that the outcomes of people who have genetic counselling, whatever the diagnosis, they manage the diagnosis much better. We get involved in support with carers, with Huntington's disease groups. We have been able to reduce admissions and reduce delayed transfers of care from secondary care. And we have significantly reduced agency costs and placement costs. And a big push of our work is actually to train other people looking after our clients in the community, wherever they are. And that's a continuing role. For the future, I think we want to carry on evaluating the service and expanding it and developing our roles as experts in the area. And I'll leave you with the image of us working with a number of clients in a variety of settings.
We have a carer with us today, and,
Yes.
and Jackie from the Huntington's Disease Association as well.
So with you for questions.
Hi, I'm Jane Onyet. I'm from the Clinical Psychology Training Programme group, one of your competitors.
But I know you, so it's okay.
As I understand it, carers were involved in the design delivery of the service. How have you evaluated that what you're actually delivering now is what they asked for? Have you got an ongoing process of feedback?
I think a variety of things. Once we have an annual get-together with families and clients with Huntington's disease, organised by the Huntington's Association, when we have an open presentation and seek feedback there. We're just beginning to actually put out some simple questionnaires to our clients and to not just clients and families, but also to care staff in homes, and people in the community looking after people, looking at their whether they've gained. I think issues between people in knowledge. People are lacking in knowledge in Huntington's. They're very afraid of Huntington's clients looking after them. They've got a huge anxiety of the future, and we're looking at people's capacity to cope with the future and see if our intervention is helping there. So that's something that we're just beginning, it's ongoing.
Sounds fabulous what you're doing. I just wondered, you said you've got a high number of Huntingtons in your area. How many families you can service with this type of quality care that you're putting out?
We have a constant, with 2 years now I've been running, or 2 and a bit, we have a constant active caseload of 50 plus clients and families. And that seems to hang around 50 all the time. The majority of those are actually living in the community, and a smaller number are living in nursing home care. But I think we're going to get more and more being supported in the community as time goes on. That seems to be a constant caseload. You'd expect in our area to have probably about 70 or 75 people actively with Huntington's, but it's a family disorder. So, you know, one person with Huntington's may have 3 children, 8 grandchildren. Those 11 people, 50% of those will inherit Huntington's. Okay? So you're not dealing with the patient, you're also dealing with the anxiety and the fear and the prospect of having the illness themselves in the other generations beneath them. So it's a much bigger client group than you actually realise.
So that's a really important question. I think with the team have been proactive in training other members of staff who are delivering the care. When they deliver that care, can offer the support as well. They couldn't before.
Yeah.
And you know, it is a critical point.
The issue of specialist service was also a challenging one, because the question is, what is a specialist service and who's involved in a team of specialists? Because there was a medic with you in the assessment day, I can't remember, female?
Yes, psychiatrist.
Oh,
Psychiatrist came along with us, yes.
Sorry.
Yes.
An acknowledgement from very senior medical staff that the expertise on this simply doesn't lie with the medical community. And so you heard Tanya say at the beginning, the carers and the clients didn't want a long-term medical solution or social solution. So the special service was given by a group of people who were not a traditional team led by a consultant, etc. Really involved. And in fact, as I recall from the conversation, it was a huge issue for GPs because the the danger, as I
Yeah.
recall, was that lots and lots of these people without a special service would be occupying hospital services, and if not, have their long-term care beds in institutions, which was not what the clients wanted. You did a little bit of cost analysis, don't you?
We've actually,
did.
we moved,
7 people.
yeah, I think we have to bear in mind that where we placed people, the standards of care in those arenas was not good. We didn't know that it wasn't good, and it wasn't actually until the team were going in and sort of seeing what was happening there that we realised that things weren't right. So we brought these people back, and in bringing back 7 people, we saved £250,000. We brought them back locally. And people will say care at home is really expensive, and yeah, on some cases it might be expensive, but the team has paid for itself year on year, just by avoiding.
I think not only did we bring them back, but their quality of care was proven to improve, bringing them back. People report, I mean, all the patients actually put weight on since they've been moved into alternative nursing homes. Their relatives report they're all looking more kempt and better dressed and looked after. And they've actually all reported that staff attitudes in the homes we've moved them to are much more positive and much more knowledgeable than the specialist home which they were previously. So there's lots of evidence actually it's been a positive quality improvement of life for these people.
Thank you very much. I'm very interested and curious. Tell me, at what level are people, is it part of the NHS system, or for people like people with dementia, are people care in the community, it's the social services who are mostly organising them?
This service goes right across the pathway, so it goes from before somebody's even diagnosed, right through to end-of-life care.
Right.
And where the individual is on their journey will depend on, who actually delivers that care. So it could be in the very early stages, they had no support, and then maybe some domestic support, and then it will go up. But at each
So
point,
at that level, it's social care.
We may well be involved as well.
the team may well still
Yes.
be involved.
It depends upon the needs of
Because-
the client and the family.
Because what I'm curious to know about is, do the patients have to be means tested?
For
No.
this service, no.
No,
Not at all.
no, no.
So that your care so there's, in social care, they're means tested. And the problem there, which I'm intrigued to know for you, once if somebody is over a certain level amount of finances, if you like, not only do they not get any financial support, fair enough, but they don't get human support either. You just get an agency book given to you, and you've got to sort it out yourself.
We're an
Whereas
NHS service, so
you
we're
are an
free at the
NHS
point of
service.
access
So that's really interesting.
throughout the whole condition. And we help people manage that system, the social service and the NHS, the
Right.
funding system. We help people negotiate that because it is complex.
Yes.
And the benefit system as well, actually.
So you
No,
do
so
that
it's-
irrespective of their financial situation?
Yes.
It's
Yes,
purely
you would.
real help.
Yes.
Thank you very much. That's interesting.